Good. So welcome, everybody. Welcome to the Quality and Safety Network's webinars. We've had a few already. It's very good to see a few of your names popping back up to this webinar today. Just a reminder for those who are new to the experience, we are organizing webinars to share best practices and experiences around patient safety in Europe, just to have an idea of how our systems work and how we can discuss patient safety issues differently. As you've seen, we've been hosting these webinars since 2019. You see all the topics here. Every time another experience. So it's really good to share everything we have to learn from each other. We have more and more to come yet in 2022. So we'll have an experience in December about how a Belgian breakthrough series collaborative intended to improve patient safety in hospitals. And then already in 2023, we'll have Denmark explaining how they are doing 7 years after the end of accreditation. If you want to pitch in, you're more welcome to come to our webinars. Today, we have a lot of people over Europe trying to listen to the German experience. We have 14 countries represented, which is really good. So I won't be talking more. I will leave the floor to Dr. Doris Voigt and Dagmar Luttel, who will explain how in Germany adverse events are analyzed and used to improve patient safety. Doris, it's your turn. You can share your screen and we'll go down from you. So I confirm you, I can see your screen.
Thank you very much, and thank you for the nice introduction. It's a true pleasure for me to participate actively in this network's webinar. My name is Doris Voigt, and I'm a policy officer at the German Hospital Federation. Since more than 10 years, my professional focus lies on quality assurance of hospitals. By background, I'm a specialist in obstetrics and gynecology with an international MBA in hospital management. Today, the topic of this webinar is critical incident reporting systems in Germany. And the webinar consists of three parts. First of all, I will give you a brief overview of the hospital sector in Germany and will present the legal framework for risk management and error management in German hospitals. Then Mrs. Little will present the findings of an evaluation project on CIRS in Germany. Mrs. Little has been working at the German Coalition for Patient Safety since 2016. And before that, she worked in the NHS patient safety team for over 10 years. She has a nursing background. And in the third part, I then will explain to you an example of such a CIRS, a critical incident system. A few words about my employer. I'm working for the German Hospital Federation, which is the Federation of National and State Association of Hospital Owners, regardless of their ownership. We've got public hospitals, private for-profit, and private not-for-profit or charity-based hospitals. We basically represent the entire range of interest of the providers of hospital care in Germany. And you will notice on the slides, I've put links on the slides wherever it suited and wherever it was relevant, so you can look that up in original homepages. The German Hospital Federation is a partner to policymakers, political and administrative institutions, stakeholder associations, and researchers. We also are represented on the international and European level. We are a founding member of HOPE, have our own office in Brussels, and we represent the German hospitals at the International Hospital Federation. All European institutions set binding law, which affects the delivery basically of the day-to-day healthcare in Germany. And the German Hospital Federation is monitoring all relevant policies coming from the European level. For our understanding of today's concept, it is important to show you something about the self-government in the German healthcare system. The German my employer is one of the leading actors in the German self-government in the healthcare sector. Other actors are, for example, the health insurers, the medical associations, nursing associations, and many more. And they are all members of the Federal Joint Committee, which is the highest decision-making institution in the German healthcare system. And it is responsible for binding decisions regarding provision of inpatient, ambulatory care services and dentists. And they deal with basically all issues regarding patient care, reimbursement of health services, provider quality assurance, quality management, and implementation of DRGs. Our headquarters is in Berlin. We have got about 100 employees in 10 departments, and we are dealing with basically everything that concerns hospital issues. Just a few words to the hospital sector in Germany. There are 1,903 hospitals at the moment. The ownership can be different, privately, publicly, or non-profit hospital. They are treating 20 million inpatients and 21 million outpatients. And as in many other countries, in some regions, hospitals are the major employers. And there are at the moment 1.2 million employees that provide patient care. The financing of hospitals in Germany is unique. There are two different ways of financing hospitals. On the one hand, it's the federal states that invest into the infrastructure, for example, building new hospitals, refurbish them, or purchase medical equipment. On the other hand, there are the health insurance fund that pay for the cost of treatment according to the DRG. There are so many political goals affecting our work, and I want to mention two important ones. That's at the moment the overcoming of the former strict borders between the healthcare sector of the hospitals and the ambulatory care sector. And also there's a tendency towards ambulatory care sectors in hospitals as the outpatient share is continuously growing. I brought you 3 slides that I want to go briefly through just to add to your understanding of the hospital sector in Germany. There is about 1/3 of the hospitals non-profit. You can see that in the middle. There's less than 1/3 public hospitals, and most of them are private. But if you look at the beds, you see that nearly half of the beds belong to the public sector, and only not even 1/5 belongs to the private hospitals. There's a tendency, a growing tendency towards reduction of hospitals, and you see that it's a steady decline also of the beds. The same accounts for other parameters used in the analysis, such as the average length of stay. And you note that with the onset of the pandemic, you had a rapid drop of cases and occupancy rates of the beds. So far to the statistics. And we come now to the core issue of this webinar. In 2008, a brochure was published called Learning from Errors. And it was published by the today employer of Ms. Little, the Coalition for Patient Safety in Germany. And in this brochure, 17 health professionals admitted medical errors during their careers. It was at that time widely noticed and discussed in public, and there was observed a kind of paradigm shift in safety culture. That shift meant shifting from the blame of a single person towards the weaknesses in the system. And the philosophy behind was, only when you recognize errors, you can work on their avoidance. So since then, many hospitals have started to identify and analyze systematically, and the focus is on systematically, errors and implemented preventative measures since then. In February 2013, the Patient Rights Act came into force. This act strengthened the patient's involvement and access to health information in the healthcare system. It still concretizes the rights of the patient in relation to the health providers, and it improves the procedural rights for treatment errors for those affected. This act contains 5 articles that change other important laws in Germany, such as the Civil Code, the Hospital Financing Act, or the 5th Book of Social Code. And this Social Code Book 5 is very crucial for the basis of the critical incidents reporting systems, because it deals with the quality management, which made it compulsory for healthcare providers and not only for the hospitals. The focus now went to introduce minimum standards for risk management, error management, and critical incident reporting systems. The hospitals also went now to be obliged to document in their annual quality reports about risk management and CIRS. And it also introduced a patient-oriented complaints management in hospitals. This resulted in a cross-sectoral development. So it joined together the hospital sector and the ambulatory care sector, both for quality and risk management, error management, and patient safety. And out came then 2 types of different critical incident reporting systems, which were both anonymously, low threshold, easy access, and sanction-free for everybody who reported. The internal system that was compulsory for the hospitals is set for hospitals and ambulatory care settings, which includes also dentists. And the cross-institutional CIRS is voluntary, and the government has set a financial incentive for hospitals to participate, but we will come to that later. The national directives that are developed by the Federal Joint Committee are based on the Social Code Book 5, and they are mandatory to all healthcare facilities. They are so-called sub-legal norms. That means if hospitals or other healthcare settings do not comply, then they can be punished. And in this context, 2 directives that were developed from this committee are important for our understanding. It is on one hand the cross-sectoral quality management directive and the directive requirement for cross-institutional CIRS. Let's look at the first one. The cross-sectoral quality management directive focuses on risk strategy. And this goes from systematic identification, assessment, handling, and surveillance of risk. And part of this risk management is error management, which means a systematic handling of errors. That includes recognition and use of errors and undesirable events to initiate improvement and prevention processes and practice. And this error management uses different tools to apply. And one of them is the instrument of error management critical incident reporting system. It is laid down in this directive that it has to be accessible to all professionals in the hospital or in other settings in a low threshold way, easy to manage, easy to access. The objective is preventing errors and damages by learning from critical events so that they can be avoided in the future. And the key word for it is shared learning experience. Reporting incidents in-house is compulsory, but it is voluntary for staff to report. It needs to be anonymously and sanction-free, and there needs to be a team behind it to work up systematically and recommend actions for prevention. The other directive is the cross-institutional CIRS, which came into force a little bit earlier than the other directive in July 2016 and contains 6 paragraphs. And we will look today only at the most important issue included in this directive. In paragraph 3, it says, it gives all the requirements for the operators of such systems. And the interesting thing is that anybody can open up such a system wherever he wants. It doesn't need to be a healthcare facility, but it needs to be open for any healthcare provider, and it needs to give an online open access for people who want to report such critical incidents. The cases that are reported need to go into structured reporting forms. There can be any critical incidents happening, but we don't accept patient harm because it's a kind of different way healthcare settings are dealing with. The operator of such a system needs to guarantee confidentiality. So it needs to be aware that hospitals and other healthcare facilities are not traceable. So personal data need to be deleted from any report, that you can identify any person, any patient, or any hospital. Behind the scenes, there are experts. There's a team that analyzes the reports and comments on them with prevention measures. And the data that have been collected by these reports, they have to be on time in the database so that they can be searched by others and used for secondary usage. And the hospital or any person who reports to the system requires a certificate of participation just to confirm that it has participated, and they need it then for the budget negotiations with the health insurer to get the money, the incentive from. So this confirmation of participation, you see it on the right-hand side. It's a very simple form, very easy to fill in. All it needs basically is the signature of the hospital that reports and the hospital and the signature of the operator of the system. And once a year, they hand it in the negotiation, in the budget negotiation, and they get the financial incentive of 20 cents per inpatient case. So that's good money. And this was set up by the government to increase the participation of hospitals, to share their experience, to share their critical incidents, so other hospitals, other people can learn from them. It's also laid down in the directive that it needs to be published in the quality report that every hospital has to publish on an annual basis. There are several checklists, and one of them contains the different external systems. And hospitals can tick wherever they want. They can tick one, they can tick none of them, or they can tick 5 to show where they have reported their cases to. So it needs to be a transparent overview, which then we use it for evaluation of the system. From time to time, we look at the figures, and this is what came out at the last time. We have a free box in the checklist in the annual report that comes on the first place. It says others. Others means there are more systems than those that we have already offered to tick in the checklist. And the second in the row is the system that I'm going to explain in the third part of this webinar. What is interesting to notice is that there are several focuses. There are systems concentrating on medical specialties like pediatrics, urology, emergency, anesthesia, and there are other systems focusing on region like that one, or on cities like the Berlin one. So they all have the different focus, and they are all very individually shaped. One of the paragraphs in this second directive deals with the evaluation of the directive. The major questions that we look for answers to are: how many such systems do exist in Germany? How many hospitals participate? And are the objectives of the directive achieved? Means, do all the partners fulfill the requirement of the directive? And the Joint Federal Committee has called for an external competition in February last year and found an independent scientific institute that has started already the evaluation. And we expect an interim report in November this year, so very shortly, and the final report in September next year. We hopefully have some interesting result. From what we know so far, and this shows the graph below, is that there's an increasing tendency for hospitals to participate in such systems. In 2016, you remember, the directive came into force, but already then hospitals participated voluntarily, and it still continues to increase. I'd like to sum up the first part. So there are two different systems, critical incident reporting systems. There's the internal one for all healthcare providers, hospitals, the physicians and the dentists. This is compulsory, and the hospitals are entitled via a financial incentive to participate and share their cases with an external provider on external platforms. And you notice it's a two-way flow of information. It is expected the hospitals participate by an input of their cases, and also to read the platform and learn from the cases that are already contained in the system. So far, the first part. I thank you so much for your attention. I know that questions are going to be put at the end of the session, but if there's any burning question already, I would be very happy to answer it.
There's no questions yet, so I will leave Dagmar to share her screen now.
Yeah.
We'll hear about first external system.
Thank you. Can you see my slides as well?
Yes, everything works.
Okay, perfect. Thank you. Yeah, thank you very much for the introduction as well, and for inviting me today to talk about our project. As Dr. Voigt said, I work for the German Coalition for Patient Safety. In German, it's called Aktionsbündnis Patientensicherheit, APS. And as an introduction, I just wanted to tell you a little bit about what we do and who we are. So the German Coalition for Patient Safety is a registered non-profit association. It was established in 2005. We have a board. There are 9 people on the board, and the 3 people you see on these pictures, they are the executive board. They work on an honorary basis. And we are a membership organization. So anyone who is interested in patient safety can become a member. And we have about 300 individuals and about 500 organizations who are a member of the German Coalition for Patient Safety. And organizations could be hospitals or health insurance funds or medical device companies, all sorts of different organizations. We are funded by membership fees and also by donations and project funding, and we are supported by the Federal Ministry of Health. We do lots of different things. So we have an annual conference every year in May, and we organize the World Patient Safety Day in September. We also, and this is main part of our coalition, we have different working groups working on different topics. So in the past, we had groups working on medical devices, infection control and sepsis, for example. And currently we have multidisciplinary working groups who look at medication safety issues, digital health, or intensive outpatient care, or psychotropic drugs. And these groups, they develop recommendations, and the recommendations are for healthcare professionals, but they also develop information for patients and carers. And you can find all these informations and publications on our website, and many are also translated in other languages. So yeah, these are the main projects we are involved or have been involved in the past. And Lüffens is one of these projects, and I'm going to tell you about this particular project now. So LIFM stands for Learning from Cross-Facility Incident Reporting Systems. These are the partners here. So it was the APS, the German Coalition for Patient Safety, then the Techniker Krankenkasse, which is a sickness fund, and then Dr. Doris Voigt was part of the project, and also Dr. Beate Müller, and she works at an Institute for General Medicine. And the project was funded by the Innovation Fund of the Federal Joint Committee and started in 2019 and finished in May this year after 3 years. So what was the project about? First of all, you heard already there are lots of different external incident reporting systems in Germany, and we wanted to find out how user-friendly are these different systems and what is the learning potential. Then the second main aim was really to develop networking opportunities between these different operators, so that also the operators can learn from each other. And then the third aim was develop recommendations for system improvements. And we had different parts in the project. In the first part, we looked at the internet and asked the providers, and the key questions were really, well, how many systems are there now in Germany? We know there are quite a lot, but how many are there really? And who is providing them? And that was the big question. Are providers interested in cooperation? Then we did a user survey, and we were trying to find out how are staff in clinical or in quality and risk departments in hospitals using the systems, and what do they need to be able to learn, and what do they want? What else do they want? And then the third part was really to establish this network and to bring these providers together and to think about recommendations for improvement. So initially we found there were 21 systems in existence from 16 operators. You can see the map here, they are all over Germany. And it's what Dr. Voigt said already, they are a bit different in, for example, who the target groups are. Some are for regions already, some are for particular topics. There's one, for example, for maternity incidents, one for medication incidents or anesthetic incidents. The operators are different. Some are like a university, or some are like a national society, or one is even a private company. Then they vary about the number of reports they had received. Some had received very few, some quite a lot. And they also vary depending on the resources they have to run the system. But what they all were the same, the incident reports are published and can be searched, and the incidents are analyzed by experts, and users can provide feedback on reports. And what was very important for this project, that there was a willingness to network and to get involved amongst the operators. So this was the second part. Then we asked staff working in risk and quality departments about how they use the system. Out of all the people we had asked, 88 used these kind of external incident reporting systems, but only half of them use the system on a quarterly basis or even less frequently. And there were only 17% of the people we asked who write comments on other people's reports. And yeah, 2/3 of the people surveyed, they said, yeah, we quite like the system. We we see lots of benefit, but there were also some people who said, well, we're not quite sure we are there, we're making the best of it. The benefits really they described are where there is a real chance to learn from mistakes. The system are quite easy to use. And they also like the analysis by experts. And what they liked is the publication of cases and that they can be searched. But they also mentioned room for improvement. So some said it would be nice to have faster feedback. Sometimes we wait a long time for the experts to come back with recommendations. They suggested it would be good if the different systems network, and that was what our project is about. And they suggested it would be good to focus more on action and recommendations. And it would be good to have a statistical analysis of the data. So this was the third part, really, to bring the systems operator together. And initially, it was all planned, like having, meetings, getting together and have a nice dinner, have a nice meal. And then the pandemic really got in our way. And everything we could do was only online. So we tried video calls where we were bringing small groups of people together so they get to know each other and they explain to each other how they work, what they do, and then they agreed on the type of cooperation. Then we had online workshops where the operators agreed on specific topics and suggested recommendations as a basic for further discussion. And then we had 3 larger conferences where there were not only the operators, but also users, and they discussed which these other recommendations go to improve learning. And the main outcome are really the recommendations, which 9 system operators agreed on. So that 9 out of the 16 operators stayed until the end and participated in all networking activities and agreed on these recommendations. So the first one really is, if you heard the term CS, it means critical incident reporting system, but there's no learning in the name. And they said the name should be changed. It should really include the word learning. The second recommendations is, because the user said sometimes we have to wait long, that users should receive prompt confirmation from the system that the incident has been reported. And all operators said, yes, we're happy with this. That's what we are working on. Yeah, the user comments is a bit tricky. I mean, it says in the, what Dr. Voigt says is mandatory for the system to offer the possibility, but in reality, not many users are making comments. And the operator then said it should not be mandatory to offer the possibility for these comments. I'm not quite sure what's happening with this recommendation, we'll see. It's also, I think if you have a national system, it's completely different to these various external systems, what we have in Germany, because they have much more contact. They keep in contact, they organize events, they're much closer than what I know from the NHS with the national system. And they all agree this is beneficial for the users and the system as well. And that's what they want to do in the future. For effective measures, yeah, that's because the users said they want more focus on the actions. The operators agreed and they said, okay, we need to concentrate more on effective measures. And that's what we do in the future. Then they said the systems, it sometimes it seems they're only aimed at those working in this departments, but that's not how it should be. It should be addressed at management levels as well. And they said, okay, we normally get only data about what went wrong, but we should focus on what went right as well, so the safety 2 approach. And they agreed that after the project, all these system operators will continue to meet on a further basis and work together. And I'm saying a bit about that in a few seconds. And this second last recommendation was a good idea. It was to build a technical search base so that you can basically add a keyword somewhere and get the results from all the existing systems. But unfortunately, not all operators agreed on this recommendation. So at the moment, there's no further work on this one. And the last one was that system operators, they're really underfunded, I would say, and they suggested there should be a basic funding for the systems. And that's what they are working on as well. Then we asked the users about these 10 recommendations to see what they think. And the highest percentages were really on the measures. So they all agreed the focus should be on measures. They liked that recommendations are for the management as well. They all liked the technical search base and to receive a confirmation. Well, I think you see from the project that it's quite, I think it's unique system of an external incident reporting system. It's not a national one, but lots of external ones. It creates this bond between users and the operators, but the system themselves are underfinanced. But in this project, it was really possible for the first time to get these different operators to work together and agree a list of recommendations. And the operators, they were initially very skeptical about the project. And at the end, they were quite surprised by how good it all went and how they shared the learning, and they were quite happy. And we asked them at the end, we sent them a little questionnaire, and they said, yeah, we would like to work together after the project. And in May, they got together for the first time. And I heard there's another meeting planned at the beginning of November, which I think is quite successful. Yeah, this is my presentation. Thank you very much, Dr. Voigt. I stopped sharing.
Yes, so Dr. Voigt, you can reshare your screen so we can end the presentations and go over.
Yes, thank you very much. As promised, in the third part, I'm going to show you how such a system works. The example is the Hospital CIRS Network Germany 2.0. It's called in that way because it has changed slightly during its existence. It was founded in 2010, and the German Hospital Federation was one of the co-founder. As I said, you can look that up if you click the link, and it shows you at the entrance this first page. And I go with you through the different parts of it. In the center, you've got a button that says, if you press it, you can both report and look at the platform, which contains all the different cases. On the left-hand side, you've got a list that you can click that explains your details, how to use this system. what can be reported. So what is the case of interest? Reported are critical incidents only, no patient harms. Who is addressed by the system? How you can report? The procedures, what do you have to respect when you give in your input? It tells you something about the structures and the people behind the scenes. So who is organizing that and who is responsible for the comments and who is in charge of the project. And then look at the right-hand side. You have, again, the Hospital Federation. You've got the German Medical Association and the German Nursing Council, who are in charge and who are running the project. When you click on input, so your Berichtsformular, so you look for the form, the structured form, everything is made very easy. It shows you like that, and you can choose in some of the boxes and scroll down different options. You can select, for example, the specialty, so the medical specialty where the case happened, where the incident happened. You can tell the patient's age group, you can tell patient sex, where it did happen, where's the location, then the context. So was it a diagnostic setting? Was it a therapeutic setting? And then you find a couple of empty boxes that you can fill in. So what happened, and this can vary from 2 lines, just saying what happened, until a whole book of information about the critical incident. The next box asks you what the result was from the incident and where you see the reason. Yeah, what is your impression? So who reports it? What did he think is the reason for this critical incident and how it could be avoided from their subjective perspective? Are there any adverse events? We need to ask that. But as I said, if they report any harm, then we have unfortunately to delete, because this is not the right place to deal with patient harm. That goes a completely different way. And the last thing on this page is asking for the contributing factors. So such as communication problems in the team, between different professional groups and so on, education, training level of staff, then the team factors, organizational problems, or any technical reasons responsible for that, or any medication problem. So if you look at the top and you choose Fallberichte, that means cases, it opens up a whole page of the content of the registered cases already elaborated for publishing on the homepage. And at the moment, there are 2,500 cases you can look up. And if you look for some specific issue, you have a search field here. You can put in a keyword and it opens you up all the different cases, reports, and comments that have to do with this subject. Another button at the top left side, news, opens you up statistics. If you're interested in seeing figures about, for example, who reports, then you've got information about the nursing staff, about physicians, pharmacists, or other professional groups who reported. Then you've got a list of cases of the month. We select one typical or interesting or relevant case for months, and that gets widely distributed. The German Hospital Federation, for example, sends it out to their members and they distribute it among the hospitals, so everybody's aware of the case of the month. And we made the experience that it's widely discussed and hospitals are already waiting for the next case of the month. Then you've got a list of interesting cases and a list of typical cases. You have also on the homepage start page an archive of reported cases of the month, and this goes really back for a couple of years, and you can look them up because they have anything very important or peculiar, so that they have been selected as a case of the month. As I said in my first part, that hospitals can voluntarily report to those systems. And if they are interested in, not all hospitals though are interested, they can have a confirmation of participation. That is this form of conformity that I showed you earlier on, that gets signed by the operator of the system, and they can use this form and get some money, the financial incentive that the government has set up, and can claim for it. And therefore is a whole page of explanation how to do that, and that is basically safe and anonymously, that it cannot be retraced, but they have somehow get in contact with the hospital in order to send them the confirmation form. I'd like to sum up the relevance of all we have heard in today's webinar. The government has sent an incentive for hospitals to participate in these external cross-facility critical incident reporting systems. And they said risk management must be lived. And from time to time, it needs stimulation and incentives to keep it alive. So therefore, it is an attempt to get hospitals to share their experience and help other hospitals to prevent those critical incidents. In the German healthcare system, it's an ongoing development of safety culture. We have seen many strong efforts from many sides in the healthcare system, and it's so far not finished yet. Critical incident reporting system as an element of risk management in hospital. They increase safety and quality of care, and everybody, all partners dealing with these systems, they are fully aware of that. It increases patient and employee satisfaction because it standardizes procedures, and is, of course, lowers the cost of a healthcare provider because they prevent errors. And there are huge advantages for hospitals when they are participating and reporting to these systems. It's so little effort. It's anonymously and sanction-free for the members and for the staff, and it's voluntary. They share their experience, they raise awareness for critical incidents, and at the end, they get a little bit of money for that. And if you have time and you're interested in, on our homepage on the German Hospital Federation, we have a couple of hospitals who gave us best practice examples on how they used these systems and what they have made out of it and what they have learned. And if you look them up, might be of benefit and of interest for you. So far, the third part, I finished that. I thank you very much for your attention.
Thank you very much, Doris and Dagmar, for both your presentations. There has been a question in the chat, so I will be reading it out loud. So thank you for your presentation. That's the first comment. And then there's a question about anonymity in both systems, where the question is it compulsory for health providers at the end of the health providers, or only for the central system? That's the first question.
So it refers basically to what I said. Yes, anonymity must be guaranteed, and it is guaranteed by both of the directives. Yeah, the only time when you have to open up your identity is when you request the certification of participation. That's the only moment. But otherwise, both the hospital and the patient, everything is anonymously, and it should not be included in the report any detail of any patient. This is a requirement. Otherwise, the whole system would not work.
Mm-hmm. Okay. Also, another question that was offline, because I have somebody who couldn't make it to the webinar but had a question. So it's about the Flemish part of Belgium here. The regional system in Flanders then is thinking about making a regional system that would go for every hospitals. I understood that it is mandatory to have this system of introducing critical adverse events in the system in Germany, but how does the government, is it national level or regional level, that has a role in this overseeing critical events being analyzed and shared? How does it concur? What recommendation could you give to a country or a region that is thinking about putting it as a mandatory thing? And there's some recommendation that Mrs. Little explained, but what would you say?
Whom do you want to answer? Well, it's very difficult to give a recommendation if you don't know exactly the circumstances and the framework of where this person lives. Yeah, this is very, very important. The system, as we described it today, is functioning in Germany because there are certain circumstances and situations where it can happen. To make something compulsory is always connected with a risk. Yeah, if you apply pressure on part of the healthcare system, the pressure will deviate in some other parts, of course. So the critical incident reporting system is working fine because it is voluntary and because people want to share and because people understand that it is a benefit for them to share their experiences and to learn one from each other. The only compulsory thing in the whole system is that the healthcare providers, be it hospitals or ambulatory care settings or dentists, they have to establish such a system. Yeah, the establishment is compulsory, but the use of this is entirely voluntary.
Okay, so you've not a system like in France where the critical events have to be reported.
No.
You have just a system to report has to be in place, which is, I think, similar in a lot of countries where you do have to have a system in place to report adverse events, but you don't impose critical adverse events being reported at a national level or regional level. That's the answer for the person that will hear the webinar afterwards. I don't know if anybody else who is connected wants to ask a question. Oh, I have a question in the chat otherwise. Who does the analysis of the adverse events being reported in the systems?
The teams that are running the systems, they have experts in place. That's the staff running the system. Together with medical experts, they are analyzing it. So
that's internally to the hospital.
Well, in the hospital, they need somebody to be in charge of it. Yes. Yeah, there need to be an allocation of tasks. Who is reading the reports? Who is analyzing them? Who is implementing preventative measures at the end based on what is in the report? And ideally, the head of hospitals is involved and organizes it together with his team.
And the external, so that's...
In the external system, it's also the team, it's the operator, but they can join any expert they want to add to their system. But basically they are in charge of their own system. If they want to fulfill the requirement of the directive, then they have to upgrade the system and make it suitable so that hospitals that report the cases really are entitled to get the incentive, the financial incentive, because of the system that needs to fulfill the requirement of the directive. Yeah, it's not the hospital, it's a third part, if you like.
Yes. Okay. Another questions. So are they financed to analyze the cases? I don't know if it's the internal system or their external system. So maybe chat in if you have a specific question, but I know there's an incentive given to the hospitals. So
right, the incentive gets to the hospital, but the financing of the system, it's a little bit more complicated because it's not standardized. So everybody who sets up such a system has also to look for how to finance it. And the operators are all different, as Ms. Little already stated in her presentation. So there are different interests behind it. There are some doing it professionally, commercially. There are some doing it on a, let's say, more private, charity-based function. So they have all different backgrounds and different kind of sources, money sources, really. And the internal system is, of course, integrated into the hospital financing system as it is compulsory. It's part of the quality assurance system in a hospital.
Yeah. I will let the chat live if I don't see any other questions popping up. It's 2 minutes to 4, so we have respected our time. I would like to thank you both for the quality of your presentations. It's really helpful to have examples of other countries so we can connect and see what we can learn from what you're doing and see what we can integrate in our system or try to change or improve our systems. You have a lot of thanks coming into the chat also. So for those who are interested, the presentation and the recording of this webinar will be available within a week. So you're free to come in contact also with Dr. Voigt and Ms. Little if you have any further questions. So
thank you very much for the invitation. It was a pleasure.
Thank you. Yes.